Hello and welcome to Psychology 36, Abnormal Psychology. This is Professor Troy, and in this lecture we're going to talk about psychosis and specifically schizophrenia and other psychotic disorders. Schizophrenia is the sort of most famous and kind of most well-known psychological disorder. Everybody's heard of schizophrenia. And it's sort of easy to think that we understand the disorder, but I'm going to talk a little bit more about the disorder and what it means to have it, and sort of the major symptoms of schizophrenia. We're also going to talk about schizoaffective disorder, brief psychotic disorder, and a couple of other disorders, just to sort of give us a more well-rounded understanding of psychosis and some of the different disorders that have the main symptom of psychosis. Okay. Schizophrenia, schizo means split, phrenia means brain. So what it means is split brain. That's the actual breakdown of the name of the disorder, but that's kind of misleading. People with schizophrenia have psychosis, and we'll talk about what psychosis means in a second. But it's not to be confused with multiple personality disorder, which was covered in the dissociative section. I didn't test you on the dissociative section, but it was covered in that. I wanted to give you guys sort of an introduction to what the dissociative disorders are, but you won't be tested on that. That would have been the last exam anyway. People with schizophrenia don't have multiple personalities. They don't think that there's somebody. They don't think that they have different identities inside them. People with schizophrenia or people who have psychosis basically have beliefs that aren't true. And sometimes they have sensory stimuli that isn't actually there. And I'll make this a little bit more clear. About 1% of the population is diagnosed with schizophrenia or currently has schizophrenia, so the numbers are typically low. Schizophrenia typically doesn't get diagnosed fully until early adulthood, and the most common time for a full psychotic break is about 25 years old, although you can sort of see strong symptoms at the age of 18 and sometimes even early if you know what you're looking for. But again, there's a lot of information coming at you at the same time, so let me back up a little bit. Psychosis is specifically defined as being out of touch with reality. And unfortunately, that definition isn't the most clear. Sort of unless you've seen psychosis, unless you've experienced it firsthand, saying being out of touch with reality really doesn't do it justice. It doesn't really explain what's going on when you're talking about psychosis or schizophrenia in particular. Let me talk about some of the positive and negative symptoms of psychosis first, and then we'll go from there. Now, remember something. If you think back to Intro to Psychology and you think back to behavioral theory and learning, positive and negative didn't mean good or bad, right? Positive for positive reinforcement meant adding something, and negative for negative reinforcement meant taking something away. So positive means adding, negative means taking something away. When we talk about psychological disorders, and we talk about psychosis in particular, if we talk about positive or negative symptoms, positive symptoms are symptoms that are present or symptoms that are present that shouldn't be there. Negative symptoms are symptoms or behaviors, things that are missing that should be there. And as I go through the slides, this will make more sense. Okay, so positive symptoms of schizophrenia. All right. Actually, let me make this slide bigger here. Positive symptoms of schizophrenia are things that are there that shouldn't be there. Okay, so hallucinations, delusions, disorganized speech, or looseness of associations. These are all what we would call positive symptoms. A hallucination is any sensory experience. So if you think about your senses, you have the 5 senses: hearing, seeing, touching, tasting, or smelling. Any sensory experience of something that's not really there. So somebody could hear somebody talking to them, or hear voices in their head telling them that they're a good person or a bad person, etc. That's not really there. That's a positive symptom. I've had patients that have voices in their head telling them to hurt other people, telling them to hurt themselves. I once had and I've had patients telling them that they have superpowers, things like that. And those are what we call auditory hallucinations, symptoms where you're hearing something that's not actually there. You could have visual hallucinations where you see something that's not there. You see a person in the room, you see objects in the room. That certainly can happen. You can even have olfactory hallucinations, smells. You can smell something that's not there. I actually once had a patient in the hospital, and she told me that she smelled Jesus. And she swore that he was standing in the room with us at the time. So that would be an olfactory hallucination because she smelled something that wasn't actually there. Um, those are examples of hallucinations. Okay, those are different from delusions. A delusion is a strongly held false belief. And in the next slide, we'll talk about some of the common delusions. But a delusion is believing something is true that's not true. Um, I once had a patient in the hospital that believed that every hospital staff member was conspiring with her husband to keep her away from her children. So she believed that her husband paid us to diagnose her with schizophrenia in order to keep her in the hospital so she didn't have access to her own children. Okay, and that was a delusion, right? It was a strongly held false belief. It was a belief that was not true. Despite whatever evidence we gave her that it wasn't true, she still believed the delusion. And the interesting thing about delusions is that people are rigidly tied to these delusions, excuse me. So any information that you give them to try to counter the delusion, typically what they'll do is they'll fold that information into the delusion and make it fit. It's kind of amazing. So that patient that I was seeing that believed that her husband was paying us, to keep her in the hospital, when I said something like, I'm not getting paid to keep your husband in the hospital. Like, the hospital pays me directly, and it's got nothing to do with, your stay here. And I said, in fact, to go even further, it actually almost benefits me if you're not here, because number one, you've gotten better, and number two, I'd have fewer patients to see, right? To try to combat the delusion. And her response was, well, that's exactly what somebody who's getting paid to keep me here would say. So clearly you have to be getting paid to keep me here. And it's just kind of amazing at how quickly she folded that into the delusion. Disorganized speech, looseness of associations, it's quickly defined down here if you look below. So disorganized speech is considered a positive symptom because the thought is that there's a lot of different thoughts going on in the person's head that shouldn't be there. And the way that we become aware of these thoughts within the patient is by hearing the disorganization of speech and the disorganization of thought, content, things like that. Okay? Examples of delusions. These are sort of common examples of delusions. I'll go through a couple of these. I don't want to go through too many because, again, this video limits me to 15 minutes, so I want to make sure I get through everything I can get through here. Sin and guilt, persecution, control, grandeur, hypochondriasis, jealousy, erotomania. So delusions of sin and guilt. It's very common that people will have beliefs that something that they did caused harm to somebody else. I'm trying to think of a specific patient example that I had. But there's certainly clients that believe that I had one client who believed that his family was suffering because he had a same-sex relationship that he was feeling very guilty about. And it was just not he just didn't feel comfortable. Culturally, for him, that was very taboo, and it was something that he didn't feel comfortable with, and he had this same-sex relationship, and ultimately, he believed that his mother was very, very sick because of it. She never even knew about the same-sex relationship, but she was getting sicker for totally unrelated reasons, but he had this very, very strong belief that his relationship with this other person was causing his mother's medical demise. Delusions of control. I've had patients, I'm just skipping down a little bit. Delusions of control. I've had patients that have sat there and told me that they can control my thoughts and they can control what I'm thinking, and they can sort of dictate what I'm going to say next. This is a delusion of control. Okay. Delusions of grandeur. This is the last one I'll talk about, but delusions of grandeur. Well, I'll talk about this one, sorry, and hypochondriasis. People of grandiose delusions believe that they sometimes have superpowers or better than other people. I had patients that believed that they could cure illnesses, cure diseases. Patients who believed that they were messengers from God, things like that. And these are sort of delusions of grandeur. If you think back to bipolar disorder, when people are manic or hypomanic, they also can have these grandiose beliefs and ideas. And going back, this is one of the reasons why some people argue that bipolar disorder is a psychotic disorder, because grandiosity being one symptom tends to overlap between the two disorders, but I just wanted to connect those two. Hypochondriasis, believing that there's something wrong with you that isn't there. I once had a patient that believed that there was a creature inside of her body eating her alive from the inside out. And she believed that smoking cigarettes kind of calmed down the creature. So the only way that she can stop her body from being eaten from the inside out was by smoking cigarettes. So she was constantly, bothering the hospital staff to allow her to smoke in the hospital. Okay, negative symptoms. Negative symptoms are things that are missing within the patient that should be there. Not symptoms, but behaviors, thoughts, things like that. Affect is your visual display of emotions. If you smile, if you're sad, your face responds to these things. And there's people that have what we call flat affect. There's also constricted affect or blunted affect. It's different levels of the same thing. But basically, people with schizophrenia or psychosis tend to have limited facial expressions, and it's very disconcerting to be with them because it's hard to talk to somebody that doesn't really display what they're thinking or feeling on their face. There's a video that I put in that Word document, and it was the patient advocate interview. It's brief. It's about 2 or 3 minutes. And if you look at that guy, he is suffering from schizophrenia, and he's got very, very constricted and blunted affect, right? Very limited facial expressions. You can see his face is kind of deadpan. And if you watch the end of the video, he kind of mumbles it, but he says, I think somebody's trying to shoot me, with absolutely no facial recognition of this at all. Almost anybody I know, if they felt that somebody's actively out to shoot them, would be showing some type of fear, anxiety, horror in their face, and he's got nothing. There's nothing there. Catatonia is lack of movement or frenetic movement. It's rare to see patients that are catatonic. This is a very old video, about 45 seconds, of a catatonic patient, and just no movement at all. And the patient is experiencing something that we call waxy flexibility, where you can move them into a particular situation. That's the waxiness, right? They can move. But then once you move them in that position, they will hold that position for hours and hours at a time. It's catatonia. Okay. Again, that's very, very rare nowadays, but it does happen. Okay. Non-active symptoms of schizophrenia can be seen when sort of positive and negative symptoms aren't present. This is pretty straightforward, right? Odd beliefs. They might sense someone who's passed on, right? It's all in the context of these things that are going on within the patient that are just out of touch with reality. They just don't make sense in the real world. Okay. Now, in order to diagnose somebody with schizophrenia or a psychotic disorder, time is a factor. It's always a factor. So if you look, you can have all of the same symptoms, but depending on how long they last will influence the diagnosis. I say that a little bit differently. The length of duration of the symptoms dictates the diagnosis that's available to the clinician and to the client. So if a person's demonstrating these psychotic symptoms for less than a month, we would diagnose them with brief psychotic disorder. The symptoms could be the same, but less than a month, brief psychotic disorder. For at least a month, but less than 6 months, we would diagnose them with schizophreniform disorder. And then for 6 months or more, and not caused by drugs or alcohol, we would diagnose them with schizophrenia. Okay, symptoms are all the same for these. The only difference is time. Okay, now, even with full-blown schizophrenia, the person typically doesn't get diagnosed until at least the age of 18, and it usually happens closer to 25. At 25, they have what we call their first full psychotic break. That's when they really become very psychotic. Prior to that, you'll see symptoms that might be indicative of psychosis, but might not be. The symptoms would include having less than 2 friends, preferring to socialize in smaller groups, feeling more sensitive, not having a steady relationship. These are very mild-seeming symptoms, but if they're chronic, it's something to pay attention to. They also tend to have odd ways of speaking and odd ways of behaving, and they tend to act just strange. They might have odd drawings, they might have odd poems, things like that. All of these things are could be indicative of schizophrenia, but not necessarily. We're running out of time in the video. I'm actually going to add a second video to this to sort of pick it up and make sure we get through schizoaffective disorder and other disorders. So we'll stop here.